So welcome everyone. My name is Melinda St. and I am the Director of Public Citizens Medicare for All campaign. And I'm thrilled to welcome you to tonight's virtual Connecticut COVID-19 Medicare for All Town Hall, co-led by Medicare for All Connecticut. And we are co-sponsored by Progressive Democrats of America, One Payer States, Justice for All Network, Quiet Corner Shouts, Physicians for a National Health Program, Connecticut, Healthcare Now, Center for Popular Democracy, and Be a Hero. We've gathered virtually here tonight during very uncertain times. The COVID-19 pandemic has laid bare the dangers of our profit-driven healthcare system, and many of us and our loved ones have been touched personally by illness, by job loss, financial worry, parenting challenges, and fear for the future. Connecticut alone has more than 50,000 confirmed COVID cases and nearly 4,500 deaths, and 193,000 people are unemployed, which is especially terrifying when your health insurance is tied to employment. But Connecticut activists are resolved to work to transform our healthcare system, and that's what tonight's town hall is about. To learn from experts about Medicare for All and to get involved in your community and take action. We're honored that we will have with us tonight Senator Richard Blumenthal, who was an early co-sponsor of the Medicare for All Act of 2019. And experts will discuss the racial justice, economic, labor, and public health implications of Medicare for All. We will hear from each speaker and we'll have time for 1 or 2 questions for each of them. And so please write your questions in the chat box. Tonight, unfortunately, under the webinar format, only panelists can speak, but we do want you to interact with us. So please do put your name and where you're from so we know where you are, and please ask your questions. If we don't get to your question, we will follow up with you afterward. And after our panel, we will hear from Senator Blumenthal, who will share his response and insights. Is the senator with us yet?
I am with you.
Hi, welcome. Would you like to say an introductory words before we get started?
I am just, first of all, very, very grateful to all of our panel. I think I may have met a number of you, certainly Erica Watson, thank you for being on. But all of you are really the experts. I can just tell you, I feel a little bit like this is an idea whose time has come, at least in spirit. I first endorsed it in, I think, 2016, and then I stood with Bernie Sanders as an original co-sponsor of the bill in 2017. So I've been on board for as long as there's been a bill, and I'm very, very proud of standing with Senator Sanders. Then I think it was 2 or 3 of us, a handful, and now it is over 17, I believe. But we're making a lot of progress, and it is due to your activism, folks on this line who are willing to stand up and speak out for healthcare, which is a human right. Healthcare is a human right. Thank you all.
Thank you so much, Senator, for those words. Now I'd like to turn it over to Stefan Ramdoor, a member of the all-volunteer grassroots group Medicare for All Connecticut, to start us off and introduce our speakers.
Thank you so much. Thank you, Melinda. Thank you so much, Senator, for joining us tonight. Thank you so much to all of the panelists and everybody, all of the attendees. This is wonderful. My name is Stefan Ramdoor. I'm a member of the grassroots group Medicare for All Connecticut. And Medicare for All Connecticut is fighting for a Medicare for All single-payer program. Some of the past activities include, for example, handing over 17,000 signatures for Medicare for All to Senator Chris Murphy to encourage him to sign on, as well as passing Medicare for All municipal resolution in New London. So yes, I'm really so grateful to have the opportunity tonight to introduce all of our panelists. So we're going to start it right off. And once again, we also want this to be interactive. So please, everyone, write your name, your town in the chat. Of course, also write your questions. and we will get back to everyone. We want to hear from you, and of course, yes, we want this to be interactive. So first of all, our first panelist for tonight is going to be Erica Watson. Erica teaches high school science by day and adult education biology and STEM at night. She's also part-time professor of human biology at Eastern Connecticut State University and a doctoral candidate in health science with concentrations in clinical health and clinical nutrition. Mrs. Watson's most recent passions include bringing awareness and implementing appropriate responsive programming to racial injustices occurring in health, medicine, and education. Erica, take it away.
Thank you, Stefan. Thank you, everyone, for having me here. You know, I'm just grateful. I'll just say that. I thank God for the opportunity to share out about this critical information to better inform all of us about life-saving policies and practices. And I remember meeting Senator Blumenthal and having a brief but intense conversation about the need for this. We're going to look at racial disparities in health from a couple of different lenses. First, I'd like to break down what the different terms mean before we move forward in understanding what's going on in our systems right now. Race as a purely scientific term refers to us as a species, Homo sapiens sapiens. Race as a social construct, which I actually learned a lot about from my daughter, who's studying this, is more commonly acknowledged and what we'll focus on today. And it describes different phenotypes, family origins, and cultural practices, etc. Disparities are large gaps or differences, and health is the intended absence of disease or the movement towards homeostasis or comfort, healing, and ability to thrive. Health has a whole bunch of different meanings to different professionals and different systems, so it's important to identify those. Racial disparities in health are differences between health experiences in historically marginalized groups such as Black, Latinx, women, low socioeconomic status, and rural dwelling citizens, and those in non-historically marginalized groups such as white males. These experiences include increased risk and incidence of chronic disease, accidents, early deaths, poor health outcomes, and much greater challenges in securing appropriate healthcare services, which was what we're talking about today. Racial disparities in health then arise, of course, in groups such as Black, Latinx, Native, Asian, etc. communities. Let's investigate the mental and medical impacts of racial injustice on health. We'll start with medical. There exists a concept called post-traumatic slave syndrome. African people living in what is now the United States suffered as slaves the brutal impacts of chronic physical, mental, sexual, social, psychological, and spiritual abuse. The syndrome is what resulted from hundreds of years of this abuse. Chronic abuse, as many of us know, leads to decreased immune response, increased cortisol levels and adrenaline surges, weight changes, chronic illnesses, and more. When an entire group of humans endures these abuses across the generations, so these abuses and experiences and reactions to those get handed down through the generations, the impacts become what we call epigenetic, impacting how our genes function in order to control our body's activities. Examples here include chronic stress, pain, and disease that arise from persistent exposure to trauma, racial discrimination, low access to educational supports, and unsafe living conditions. People of African descent in this country suffer more from epigenetic impacts on health than any other group, because people of African descent in America today experience the deepest, most guttural and inherent forms of hatred that get expressed through our institutions, including economics, religion, education, and health. We see highest incidences of overweight, obesity, cancer, stroke, etc. in these groups, and yes, even overall premature mortality. The invasive and metastatic ideology that these patients are threatening, are less than, and or are unworthy leads to racial disparities in health. African Americans and others of African descent live more than any other group in food deserts, which are places where you have limited access to healthy foods, have the worst access to healthy transportation to healthy places such as clinical care, and live in some of the most crowded conditions, all contributing to the increased risk of infection, which we're going to address tonight with COVID-19. Some research posited that Black people were inherently biochemically different and therefore naturally at greatest jeopardy of contracting HIV, tuberculosis, and hepatitis infections. Finally, we have professionals who've dispelled this proposition, and we know today that it's actually environmental factors, such as close residence, and again, exposure to chronic racism. In fact, I just read a study that showed that people coming from the continent of Africa, indigenous Africans coming from the continent of Africa, did not suffer the same disparities as people who are here of African descent. And it is because of our exposure, our environment, and our chronic stress within the United States. This is the same for COVID-19. Black, Native American, and Latinx groups contract and die from SARS-CoV-2 infection more than any other group in the United States. Racial disparities in health control our current COVID-19 mortality and morbidity rates for everyone. With Native Americans and Latinx patients diagnosed almost 3 times more than white patients, and African American patients diagnosed almost 2.6 times more. Interestingly, African Americans die from SARS-CoV-2 infection still more than any other group. Mental health and incarceration rates are huge factors in racial disparities in health as well. Living near pollution, having constant exposure to violence, poor health choices, ongoing financial stress, and fear of retaliative police brutality directly contribute to depression and anxiety in these populations. High infant mortality rates, and interestingly, lower rates of breast cancer in Black women, but higher morbidity rates and lower rates of prostate cancer in Black men, but 3 times higher the death rate, make African Americans the least healthy racial group in the United States. I'd like to take a moment to consider the children in these groups, by the way, who have to rely on the adults in their communities to defend and protect them, on top of facing systemic racism even as youth. We're watching our Black and brown patients contract, agonize with, and die from this pandemic infection because of systemic racism. One simple way to combat part of this life discrepancy is to implement Medicare for all patients. Medicare for all offers low overhead costs, much lower than private insurance. And offering Medicare for all, particularly those who are most impacted by least access to healthy lifestyle and healthcare, will strengthen the healthier protective factors for Black and brown patients suffering and dying from every day COVID-19 at human evolution changing rates. Thank you.
Thank you so much, Erica. Yes, this is so important for us to keep in mind the existing health disparities. And thank you so much for all of your work bringing awareness to this issue, and how also in regards to healthcare reform, like we do have to always embed this health and racial equity lens, like in everything we do. So thank you so much. Going now, next as a speaker, we have Professor Mark Stelzner. So Professor Mark Stelzner is a professor of economics at Connecticut College with a specialization in inequality and the political underpinnings of economics. Professor Stelzner.
Hi, everyone. I'm going to share my screen here. Where'd you go? Oh, God. Okay, let me try this again. It's a good start. Share my screen. There it is. Okay. Okay, so I'm going to talk a little bit about some current work that I've done on basically healthcare spending in the United States and the reason for the very large increase in spending in the United States, and why Medicare for all would be a great solution to bring down overall spending. So the United States, it spends a lot. If you can see this graph right here, on the vertical axis, we have percent of GDP spent on private and public healthcare, so total healthcare spending for the country as a whole. from 1970 all the way to 2016. And the bottom line there is United Kingdom. The next line up is Canada. The line after that is Japan, and then France, and then that line going away from the rest of the group is the United States. And as you can see, the United States spends way more as a percentage of GDP on healthcare compared to any other industrialized country. We spend more than 5 percentage points of GDP more than France, which is the next developed country that spends the most, and we spend even more than other developed countries. And the thing is, we also have very bad health outcomes. So for example, in terms of life expectancy at birth, we're way worse than a lot of other OECD countries, developed countries. We have our life expectancy at birth is 2 years less than Germany. It's 5 years less than Japan. And in terms of OECD countries, like developed countries, we're ranked 28th out of 36 developed countries. So we do very bad in terms of health outcomes, yet we're spending an immense amount of the income we create every year on healthcare. So the question is, what's taking place? Why are we spending so much and getting such bad outcomes? And as you can see here too, back in 1970, early 1980, we spent a similar amount of our income on healthcare. And during those times too, we compared better in terms of relative health outcomes. So what we look at is change in antitrust and patent laws. So antitrust laws are basically the laws that govern mergers and acquisitions between companies in the United States. And patent laws are laws around what patent holders can do in terms of excluding competition. And I imagine everybody has heard a lot about patent laws and pharmaceutical companies and charging a lot, but we focus in on the changes from antitrust laws. And basically what we've seen since antitrust laws have changed, they started changing in 1980 through kind of changes from the Department of Justice through the courts and some changes through Congress. And what's happened is antitrust laws have basically been deregulated. So mergers and acquisitions that were previously deemed uncompetitive and weren't allowed in the past are now allowed at present. And this change in antitrust laws, this deregulation of antitrust laws has led to an increase in concentration in hospitals, physician groups, medical health insurance, and all the subsectors of healthcare. Indeed, it's led to an increase in concentration across sectors, not just in healthcare in the United States. And so this increase in concentration basically just means that there's fewer companies competing for providing service to a given group of consumers. And so the reduction in competition basically leads to those companies that are bigger to increase prices because they don't have other companies pushing the price down. And so what we do, we basically ask the question, so if antitrust law and patent law didn't change, if we hadn't empowered these companies basically to increase prices either through reducing competition through merging or through more extensively applying patent laws, what would our spending on healthcare be if we were consuming the same quantity and quality of healthcare in the United States? So we do what's called growth accounting to basically look at if concentration in these sub-industries in healthcare had stayed the same, what would spending be? And we use micro studies from these different subsectors of healthcare to look at the price effect from mergers in hospitals in like a given metropolitan statistical area or a given zip code, mergers in health insurance companies, mergers in physician group companies, to see basically what is the price effect from reducing competition from this increase in concentration. And from that, we're able to calculate 3 counterfactuals. I'll briefly talk about 2 of them here. So the counterfactuals are what spending would have been in the United States if we hadn't kind of empowered these companies to make these crazy profits at the expense of the public. And so that first counterfactual on the top, coming right down from the United States line, is it says median, and it's using the median price effect from these micro studies that we use to calculate the counterfactual. So basically the middle price effect, because all these studies agree that increased concentration, a reduction in competition leads to an increase in prices, but they disagree on basically how large that effect is. So if we take the median effect from these studies from the different subsectors, and we basically subtract out those changes from increase in price from increase in concentration, this is how much we'd be spending as a nation on both total public and private healthcare. And then this lower one here that it says upper bound, that's the upper bound price effect. So these are from the studies that found a larger price effect from increase in concentration in these subsectors of healthcare. And basically, if we look at the upper bound result, we see that the amount the United States would have been spending on healthcare would have been similar, much more comparable to other advanced industrialized countries. So what it says is what we've done through deregulating antitrust laws and through more strictly applying patent laws is we've empowered these companies basically to get very large profits, and we've done that at the expense of society because we are the ones paying for this increase in prices. And so what we find basically is that in 2016 alone, Americans were overcharged between 2.47 and 4.3 percentage point of GDP, which is equivalent to $805 billion in 2016 alone. Sorry, I said 2007 before. So there's huge savings to be made. So the idea here is Medicare for All would be a way basically of the government to come in as the public medical insurer and use its monopsony power, to use its power to push down prices and then pass on those benefits, savings to citizens, so that we can bring our prices all the way down potentially to that upper bound and potentially even further. So we could end up paying much less for healthcare and getting much better health outcomes. Thank you so much.
Great. Thank you so much, Professor Stelzner. Yeah, and thank you also, of course, for your work with helping to pass the Medicare for All resolution in New London by giving this presentation to the City Council there.
Thanks.
So now we have Wendell Porter as our next speaker. Wendell Porter is a former health insurance executive who knows from the inside just how dishonest and cynical the insurance industry is in their attacks on Medicare for All. Wendell lived in Connecticut when he was working as a senior executive at Cigna and has since become a whistleblower on the industry. He is widely published and is a founder of Center for Health and Democracy, as well as Business Leaders for Healthcare Transformation. Wendell.
Stefan, thank you very much. And thank you all. It's an honor to be a part of this and great to be back in Connecticut, if only virtually. Like Mark, I'm going to be using some numbers or providing some numbers, some that you will be hearing for the first time, some that you've heard before. But I want you to keep in mind that I'm talking about real life human beings here. People like Chris and Jenny Carulli of Turnbull, Connecticut. Chris recently, last year, was diagnosed with non-Hodgkin's lymphoma. He lost his job. He could not continue to work during treatment. He had to enroll in a health plan in the marketplace, and it's a plan with very high deductibles. He has had to turn to GoFundMe, essentially to beg for money to pay for his medical bills. And I found thousands of people like Chris and Jenny. All you have to do is go to GoFundMe and type in high deductible, and you will find hundreds and hundreds of people like Chris and Jenny who have insurance, but they can't pay their medical bills. People like Jill Eicher of Maryland, who is also begging for money to pay her medical bills. She also has cancer. Keep in mind, these were people who have jobs or had jobs, but still they are facing enormous medical bills. Since the beginning of this pandemic, tens of millions of US workers have lost their jobs, at least temporarily. And just today, the Economic Policy Institute released the findings of a study that found that at least 12 million Americans have also lost their health insurance along with their jobs during this pandemic. Now, those are numbers that you've probably seen or heard in recent months or even today. But here are some facts and figures that haven't made the headlines, but they're every bit as alarming. The pandemic has laid bare just how broken our healthcare system is. 10 years after the passage of the Affordable Care Act, which I supported and fought for, and which has done a lot of good. But one very big thing that was failing us when the law was passed and is continuing to fail us even more now is our employer-based system of health insurance. In 1998, the total number of people covered by employer-based insurance was 156.1 million. 20 years later, in 2018, it was 156.5 million. You might be thinking, well, at least that's stable. But you have to keep this in mind. The US population has increased by 55 million since 1998. So you can be certain that because of the jobs lost during this pandemic, the total number of people getting coverage through their employers is now far less than it was in 1998. Here's another way of looking at this. When the ACA was passed in 2010, nearly 70% of US businesses offered health insurance. In 2018, 2 years before this pandemic started, the percentage had dropped to 46.8%. You heard that right. Fewer than half of our employers are now offering health insurance. That's a huge drop in just 8 years. And you can be certain that it's still dropping. As Stefan mentioned, I lead an organization called Business Leaders for Healthcare Transformation. We represent more than 3,200 businesses across the country, including in Connecticut. Many of those businesses were struggling to offer benefits before the pandemic, and now almost all of them are struggling. Many are no longer able to offer coverage to their workers, and many others never could. And here's why. The year before the ACA was passed, the average premium for employer-sponsored family coverage was a little more than $13,000. That's a lot of money. But last year, it was nearly $21,000. To help offset those huge annual increases, businesses have been forced to make their workers pay more and more of the total cost. So you see, the ACA has done little, frankly, to slow the cost of healthcare premiums or the cost of healthcare overall, for that matter. But as scary as those numbers are, it is far from the only story. To paraphrase James Carville, it is not just the premium, stupid. Out-of-pocket costs for people with insurance has grown at an even faster clip than premiums. The average amount of the annual deductible for families increased 55% between 2010 and 2016. And that, folks, is why Americans are turning to GoFundMe to pay their medical bills, people with insurance. And they're doing it at a time when health insurance companies like the ones that I used to work for, Cigna and Humana before that, are reporting the highest profits in their history. And they're paying their executives record salaries and compensation as well. Insurance companies have been posting record profits since the ACA was passed, though. I knew that would happen, and I warned Congress more than 10 years ago. Speaker Pelosi invited me to talk to House leaders in 2009. I said then that if Congress passed the ACA without a strong public option, which was being considered at the time, they might as well call their bill the Health Insurance Industry Profit Protection and Enhancement Act. Even President Obama himself said that the public option was needed to, quote, keep insurance companies honest. Well, as we all know, the ACA did pass without a public option because my old industry spent hundreds of millions of dollars to kill it. And now that there is strong support, once again, for a public option, also for Medicare for All, the industry, through its front group, the Partnership for America's Healthcare Future, is at it again. They even relaunched their campaign of lies and half-truths just in time for last week's Democratic National Convention. To make Wall Street happy, the big insurance companies have also systematically reduced our choice of doctors and hospitals by slashing their provider networks whenever they want and without regard to quality. And that is why we have surprise bills. And they have ramped up their prior authorization requirements, which means doctors have to spend even more time begging insurance company bureaucrats to approve a treatment or medication they know their patients need. This practice alone leads to an untold number of deaths because of needless delays. But Wall Street is happy, and that for these companies is really all that matters. If Democrats take control of Congress and the White House next year, they need to move boldly and quickly to help people like the Cerulli family in Turnbull, Connecticut, to help Chris get the care that he needs without delay and to avoid financial ruin. Universal coverage without unaffordable copays and deductibles is essential, as is restoring the physician-patient relationship that politicians talk so much about, but do so little about because they are under the influence of big insurance. Warren Buffett has said frequently that the US healthcare system is the tapeworm that is destroying American competitiveness. it's also destroying and bankrupting families, people with insurance. That's why we must stand together and insist on nothing short of healthcare transformation. Thank you.
Thank you so much, Wendell. It's so insightful again and again to hear from you and your perspective and the business coalition that you are leading. It's so inspiring. So thank you for all of your work.
Thank you.
So now as a union worker, as a retail worker myself with Communication Workers of America, rank and file member, I'm thrilled that we have an opportunity to hear a little bit about the labor perspective regarding Medicare for All here in Connecticut. So Margaret Dabrovsky is a 911 dispatcher from New Britain, and she is the Vice President of Local 222 of the United Electrical Radio and Machine Workers of America, which has been a strong champion of Medicare for All nationally as well. So Margaret, would you like to go ahead?
Hi, my name is Margaret. Like he said, I've been a 911 dispatcher for approximately almost 23 years in the city of New Britain. I've also been a member of UE. I'm the vice president of the local 222 in Connecticut. If you didn't know, our union has been supporting a single payer Medicare for All model for healthcare since about 1943. Okay, we understand, yeah, it's been a long time. We understand that healthcare should not be tied to your employment, should not be tied to your marital status like a lot of places are. If you're married and you get divorced, you lose your healthcare. Should not be that. We should not have to spend so much money on healthcare. I myself had just experienced an injury 2 months ago. I had to wait approximately 4 weeks out of work to get an MRI so I can go back to work. I just got my brace. It's been 4 weeks since I ordered my brace and I got my brace. We should not have to deal with this. We have people calling in 911. They're afraid to be taken by ambulance to the hospital. They just want a medic to look at them because they can't afford the hospital bill. They can't afford the ambulance bill, or they wait until they're seriously ill to call for an ambulance. They don't go to the doctor because they can't afford the co-pays. They can't afford the bills. You know, I was in therapy today and I listened to a therapist talking to a client, and the client says, you know, my doctor authorized 30 more visits. And the therapist said, well, that doesn't matter what your doctor authorized. It matters what your insurance company will approve and is willing to pay. In a country like ours, it's shameful that we spend so much money on so many things, wars in other countries and everything, that people here are dying because they cannot get health care. It's just inconceivable. Like I said, we deal with this every day as a 911 dispatcher. I deal with people in crisis all the time, and it's shame. It makes me want to cry because people just can't go to the doctors. I have a $4,000 deductible, which means I have to pay $4,000 out of pocket before anyone in my family gets coverage on top of the premiums I pay. You know, you can negotiate with your doctor, you can get payments and stuff. You can't negotiate with CVS when you want your medication and it costs $800 or $900 and they want that money up front. My brace was $700. I had to pay that up front today. Like I said, there needs to be change. There needs to be change in this country for that. Thank you.
Thank you. Thank you so much, Margaret. And yes, thank you for sharing your healthcare story as well. And regarding the labor, like my fellow impression is always that union members, just the rank and file, they are really overwhelmingly in support of reform and Medicare for All specifically. So thank you so much for bringing that perspective. And once again, if you have any questions, feel free to type them into the chat. I already see a question there. We would like to for this to be interactive. Next, I am absolutely pleased and honored to welcome Senator Richard Blumenthal, who has served as Connecticut Senior Senator since 2013. As Connecticut's Attorney General, he was a key leader in the national fight against big tobacco and advocated for reforms in the health insurance industry to assure critical healthcare coverage and lower pharmaceutical drug prices. We are proud that Senator Blumenthal is a co-sponsor of S. 1129, the Medicare for All Act of 2019, and we are pleased to hear why you, Senator, champion Medicare for All and how we can build this grassroots movement to win guaranteed health care for all.
Thank you very much, Stefan. And thank you to every one of the panelists. If you've been watching me at all on the screen, you've seen me looking down, taking notes. And I want to follow up with a number of you on the specifics of what you said tonight, including, by the way, Dr. Stelzner, because I have a bill dealing with patent and antitrust abuses in the healthcare area. It actually passed the Judiciary Committee with a bipartisan vote, and it's now on the floor of the Senate. So I may be able to get from you some of the factual and legal support that might push us across the finish line. But let me talk, and I'm going to try to be very succinct because there's been so much evidence, and I was a trial lawyer, you know, the Attorney General and federal prosecutor, and one of the most difficult lessons for a trial lawyer is when you've proven your case, rest. Don't go on. And you all have presented such a forceful case for Medicare for all. So I want to add just a few exclamation marks, if I may. People would ask me often when I was Attorney General, what's the most meaningful case that you had? And I had the feeling they were expecting me to say, oh, well, the case against big tobacco was national in scope, or the case against Microsoft, you know, another national case. And I would say to them, you know, the most meaningful case is not one, it's the hundreds, maybe thousands that I've done for individuals who were denied healthcare by their insurer. And when I think of some of these cases, I can tell you tears still come to my mind. You know, the woman who had 3 young children who was told she had a pre-existing condition for a brain tumor because 3 years ago she had headaches. Brain tumors don't last for 3 years. You know, we were able to get the insurer to cover it because we told them, you know, we are going to take you to court, but we're also going to take you to the court of public opinion. I did hundreds of these cases before the ACA on pre-existing condition, on whether or not certain kinds of care were quote unquote experimental. The insurance industry has had over the years and continues to have all kinds of ways, in effect, to raise the costs of healthcare and make it inaccessible. They're not the only villain here, and maybe we shouldn't characterize them as a villain. They're just in the market to make a profit, and the law allows them to do what they do. But we need to assert healthcare as a fundamental right and to eliminate the antitrust abuses, the denials of care, the excess costs with very inadequate outcomes. And that's why I am supporting Medicare for all. I stood with Bernie Sanders at the outset. I believe that those hundreds and thousands of cases, which stay with me in my heart still, are persuading people in this age of the pandemic that this system is broken. It is fundamentally broken. When people see a 10% rise in the uninsured numbers, and that's probably pretty true of Connecticut as well, it is true nationally, anywhere from 130,000 to 380,000 people in Connecticut now no longer have insurance. People talk about COBRA as a solution. All of you know the costs of COBRA, $1,000 a month. Who can afford $1,000 a month when they are unemployed? So these folks are really denied healthcare, and you also know premiums have risen. Maybe they haven't risen quite so much recently, but deductibles have doubled between 2011 and 2018. All of the out-of-pocket costs, it's not just the uninsured, it's the underinsured. For people who can't afford to pay even when they have insurance. So let me just say what is, in many ways, the most persuasive point to me, and that is, what does Medicare for All guarantee in coverage? Preventive care. It's a cost saver. It guarantees real mental health care. We're seeing now in our state a 22% increase in overdoses, opioid overdose deaths. That is a tremendous red flag about what's going on in this state and country with mental health care and substance abuse disorder. It guarantees oral health and vision. How do kids go to school if they can't see the blackboard or they can't read their computer? And how do they really learn anything if they have a roaring toothache? It covers reproductive health care and maternity and newborn care. You've seen some of the numbers on how poorly our nation does, and home and community-based long-term services and support. These are gaps in our current system that I think we have a moral obligation to remedy and address. And I think more and more of my colleagues are convinced of it. You've seen some of the proposals that go a good ways. The Medicare at 50 Act, which would open it up to people from 50 to 64. My colleagues, Senators Stabenow and Brown, are leading it. Also, the Medicare, Choose Medicare proposal, which would open up some choice for Medicare. These are proposals that provide steps. I would support anything that goes in that direction, but the goal ultimately, I think, has to be healthcare as a right, and Medicare best recognizes that principle. And I will just finish on this note, and Professor Watson has heard me talk about it, because I've been at many of the demonstrations and marches and protests over the last couple of months in a real social movement. We're seeing a movement for justice in this country. It's a movement for racial justice in policing and criminal justice. And it began with some utterly inhumane and horrible police abuse of power. But it's also a cry for justice in housing, where redlining still exists, in education. Zip codes still determine the quality of schools in many areas. Economics, justice in the workplace, and it is a cry for justice in healthcare. There is a reason why people of color are twice as likely, 2.5 times as likely to die as a result of coronavirus. There is a reason in the susceptibility, those kinds of comorbidity and comortality factors that Dr. Watson mentioned, Professor Watson mentioned so well earlier. It is a failing of our healthcare system. It is fundamental. And as part of the cry for justice, and I've been so moved in going to these 17 or 20 demonstrations all around the state, led by young people, as many social movements are. And I hope that Medicare for all is part of our cry for justice in this country. Thank you.
Yes, thank you. Thank you so much, Senator Blumenthal. And I did see questions here in the chat. There seems to be like a very robust conversation, which is wonderful. And so one question here, for example, from Diane: what do proponents of Medicare for all currently in Congress plan to do to push a possible Biden administration to take up the Medicare for all mantle?
Maybe I should take a first crack at that. We have now, I believe we may be up to 19. I know we had around 16 or 17 co-sponsors in the Senate. I'm not sure of the number in the House, but we have a critical mass for sure. And what will we do? Well, we're going to continue doing what we have done before. We're going to be reaching out to people like the advocates on this call to make themselves heard, to my colleagues. Obviously, our readiest audience are Democrats. I'm hoping it could be bipartisan. I'm hoping that this election will teach our Republican colleagues that the Trump effort to destroy, remember, he's trying to destroy the Affordable Care Act. He's in court right now, seeking to not just tinker, but destroy the Affordable Care Act. I hope my Republican colleagues draw a lesson from this election that that's not a viable position in the long term. But we will obviously, we'll be knocking on that White House door. We will be working in our own committees in Congress. We will obviously introduce a bill, and we're going to try to make it as appealing as possible to the broadest possible cross-section. But the fundamentals of Medicare for all should be a part of it.
Wonderful, wonderful. That's sounding great. So, and we have another question from Liam directed directly at Senator Blumenthal. So, kind of also regarding the opposition, what is the plan to win support for Medicare for all within government and the legislature amidst the massive private insurance lobbying and big money interests on the side of those fighting against healthcare? Is it right?
I think that we are at a real, you know, the temptation is to use the hackneyed word inflection point, turning point, crossroads. We're at a Rooseveltian moment in our nation's history. And I think the appeal to them is that we have the opportunity to do something really big and historic that we know is also the right thing to do. And it's also the economically smart thing to do. There are folks, the experts on this call, who know much more about the European systems than I do. Dr. Stelzner gave you some powerful numbers on outcomes. We spend more, our costs are higher, our outcomes are lower. That's not a good picture. So I think on all kinds of levels, a moral level, an economic level, a political level, we are truly at a moment of opportunity. We need to seize it. What are we going to do to convince our opponents? Well, we're going to reach out to the people of America. They're going to have a chance to vote, number one. And I really think, you know, Michelle Obama said it best, vote as if your life depended on it, because she didn't say it, but in my view, your life does depend on it. And there's no better illustration of it than healthcare. And we need to get people to focus on it. You know, healthcare is something, I'm stating the obvious to everybody who's on this call, we take it for granted until we don't have it. You know, Margaret was talking about going for therapy. You know, every one of us has been there, let's face it. Everyone has had something where we need to get an insurer to sign off, if not for ourselves, for our kids. And we know it, that this system is broken. And again, not to disparage unduly the insurance companies, but because it is, by the way, big pharma, the pharmaceutical drug companies, the medical device companies, the health benefits managers, this entire system has to be changed. And the best way to do it is to begin with single payer.
Thank you. Thank you so much, Senator Blumenthal, and to everybody who put questions in the chat. We have to move on because we really do want to focus on the action component of tonight, because it's one thing to learn what we need to be learning, but we need to, I think, heed the call of a senator and others here. Really, we need a bigger ground game, I think, in order to really achieve what we want to do. So we will follow up with everyone in the chat, and if it's okay with you, Senator, we'll pass on some of the other questions to your staff, if that's okay.
I would love to get them, and I promise you we'll answer all of them, and I agree with you 100%. Rather than my talking, I'd rather hear your providing a call to action.
Great, and we also have some other questions for other panelists, and we will make sure that they answer those as well. I want to, you know, again, as I said, translate the outrage I think that we're all feeling at the state of our current for-profit healthcare system into action. We know that the insurance companies and big pharma are spending millions of dollars to block change and to spread lies about Medicare for all. And we know we're not going to be able to outspend them. It's impossible for us to do that. So we have to organize, and we have the people power and to organize that power to do that. So in Connecticut, we, as you all know, and it came up some in the chat, Senator Blumenthal has been an early co-sponsor of Medicare for All, and we thank you for that. Representative Johanna Hayes is also a co-sponsor of the bill in the House. Though so far the rest of the Connecticut delegation, though all Democrats have not yet signed on as co-sponsors, even though exit polls showed kind of throughout the country during the Democratic primary that no matter what candidate won the primary, Medicare for All always won. In many states, 88% of Democrats support Medicare for All. So we need to make sure that, that the Connecticut delegation hears from Connecticut residents, call, email, letters urging them to support Medicare for All. And we need to, and then another tactic that we have been working on across the country is to organize at the very local level. One powerful tactic that we used actually as an to try to get an amendment to overturn Citizens United several years ago was to pass local city and county council resolutions, town council resolutions in support of the policy, and got hundreds of them passed, and it really starts to change the national conversation, and we want to do that as well. So my colleague Brittany Shanahan has been supporting activists all over the country to win these local resolutions, and so I'd like for Brittany to share a little bit about those resources, and we really want to encourage you to sign up in your community to help pass a local resolution in your community.
Hi there. So I'm going to see if I can share my screen real quick. There we go. So we have a broad coalition of organizations that is mobilizing in communities large and small all across the country to win these local resolutions. There are, let me pull you up to our map. Take action, find your town. Come on, internet. There we go. I'm from the country, so it's a little slow. But as you can see, we have more than 330 resolutions efforts underway, and more than 40 resolutions have passed in communities as diverse as Los Angeles, New Orleans, Knoxville, South Bend, Tampa, New London, Connecticut, and small towns like Peterborough, New Hampshire. We just found out about St. Paul, Minnesota a couple weeks ago. And so you can sign up to join if you haven't already. You can go to our website on this page, and you can sign up to join the movement in your community, and we can connect you to folks near you. We can connect you to Stefan if you're not connected already. And we can try and pull resources with these many organizational partners that we have to get your effort going. And as well as that, on this map that I was just showing, which again is at Medicare for all resolutions.org, you can, if you click on any of these green little pins, these represent resolutions that have already been passed. So here's one for Allegheny County, Pennsylvania. So you can just click on that link and it should take you to the resolution so you can read it. And especially, it's great to look at some of the more recent resolutions where they brought in some COVID language as well. We also have a comprehensive toolkit on our website. I'll go back really quick right here for COVID-19 resources to talk not just about resolutions, but in general. It gives us a great bunch of talking points about the COVID crisis and how to really relate that into your discussions with people about Medicare for All. And again, I am always excited to talk to all of you, and I look forward to getting to know more of you and discussing all of this with more of you. Now I want to turn things back over to Stefan, who can share more with how you can get involved in all the great organizing that's been going on in Connecticut.
Thank you so much, Brittany. Yes, so I just first off want to say thank you so much to everyone for attending tonight. And of course, thank you to our speakers, Erica Watson, Professor Stelzner, Wendell Porter, Margaret Dabrowski, Senator Blumenthal. This is wonderful. Yes, how can we get active in the fight for Medicare for all here in Connecticut? So yes, we heard about it. In February, the city of New London was actually the first municipality in Connecticut to pass a Medicare for all resolution. And now there are efforts in other municipalities looking to follow New London's lead. So for example, in Stamford, we already have a Medicare for all resolution that has been introduced into the Board of Representatives. So in Hampden and New Haven, there are efforts underway. There's also conversations in some other Connecticut municipalities. So do not hesitate to reach out. Brittany, Melinda, the whole public citizen team, they are absolutely able to provide us all of the resources and to connect with other activists working on Medicare for all resolutions. Also specifically, for example, on Saturday, September 5, the next Willimantic Medicare for all resolution virtual meeting is scheduled to take place. So yeah, maybe we can post that information in the chat to join CRI-CON DSA and other Connecticut residents from the very northeastern corner of the state as they discuss how to encourage elected officials on the local level to support Medicare for all resolutions. And yeah, also, of course, in case you live in a different part of Connecticut, not mentioned here yet, as I said, there are already like some efforts on the way, and even if there isn't, we can get you started. We have all the resources and can connect with other activists. So, and besides the Medicare for all resolutions specifically, what else is going on when it comes to Medicare for all activism in Connecticut? The next Medicare for all Connecticut monthly meeting is scheduled to take place on Tuesday, September 8th at 7 p.m. And then in addition, we also have groups like Physicians for National Health Program. So physicians specifically advocating for Medicare for all program. And now, just 2 days ago on Monday, a Connecticut chapter was officially established for Physicians of a National Health Program as well. So one does not have to be a physician to join those meetings or to join the organization. Myself as a retail worker, I'm a member of PNHP. So the next PNHP Connecticut member meeting is scheduled to take place on Monday, September 14th at 7:30 p.m. And then of course, members of Medicare for All Connecticut recently also once again met with a staff member for Senator Chris Murphy to encourage him to co-sponsor the Medicare for All Act. So we'd like to schedule a follow-up meeting with the Senator's office, so in case you are interested in being part of that meeting and or scheduling in-district meetings with your representative to have these conversations. Yes, make sure to register to our September 8 meeting or just send us an email and or let us know in the chat. And then finally, also right now at 8 p.m., the Center for Popular Democracy, it's starting its own Medicare for All bird dog training. So the trainers with the Center for Popular Democracy are the folks who helped in the effort to save the ACA or fight against the tax scam by packing town halls and occupying hundreds of offices of politicians, everybody who voted to take away our health care to pay for tax cuts for millionaires. So right now, starting at 8 p.m., CPD is putting on its training session about how to most effectively ask legislators to support Medicare for all. So everybody who would like to join in that, yes, we'll put the link into the chat for that as well. So once again, thank you so much. This was a wonderful conversation. The work continues. And thank you. Hope to see you again soon. Have a good evening.
Thank you, everyone.
Thank you, Senator. We really appreciate you being with us. Thank you so much.
Great meeting. Thank you.
Thank you, Senator.
Thanks, Wendell.
Senator.
Hope to talk again with all of you.
Yeah. Great.